Hi, I'm Nikita. Welcome to my channel. This presentation will be about skin manifestations in pediatrics. One of the most precious and lovable things about children is their perfect skin. Pediatric skin manifestations is the bread and butter in primary health. And this slide is about 100 and odd slides, and I've separated it into sections. So we have neonatal skin manifestations, newborn and infant problems, fever with a rash, genetic diseases, acquired hypopigmented diseases, changes in malnutrition, changes in HIV and their treatment, and miscellaneous, which includes alopecia areata, erythema, tinea cruris, geographic tongue, scabies, sickle cell skin manifestations, and acanthosis nigricans. In this presentation, I'll talk about neonatal skin manifestations, which will include Mongolian Blue Spots, Blue Naevi, Bathing Trunk Naevi, Erythema toxicum, Milia, Neonatal acne, Jaundice, Transient neonatal pustular melanosis. Some of the topics you'll see are asterisk because these are high yield questions in the exam. Now, Mongolian Blue Spots. This is a developmental condition exclusively involving the skin. It results from entrapment of melanocytes in the dermis during their migration from the neural crest to the epidermis. The spindle-shaped pigment cells are actually found deep within the dermis. In Mongolian Blue Spots, you'll see a blue-black macule over the lumbosacral area. You may also see it on the child's shoulder, their backs, and you'll see it extend over their buttocks and extremities. It mainly happens in Black people, and it's typically present at birth and will disappear spontaneously within 4 years. There's no sexual predilection, and this can be confused with child abuse, and it's important to examine the child properly. As you can see in Mongolian Blue Spots, it's one shade of blue back all over the child. When the child is being abused, you'll see different shades like red and blue black at different stages of healing. Now, Blue Naevi. This is an acquired pigmented Naevi and it's present at birth. It's about 1 centimeter in diameter, and you'll see it vary from a pale brown to a black color, and it often becomes hairy and more protuberant with an increased risk of malignant change. So look out for this. Larger lesions may cover large areas of the trunk and buttocks, and these are called bathing trunk nevi. I'll show you a picture of this in the next slide. The common blue nevus is a flat to slightly elevated, smooth surface macule, papule, or plaque that is gray-brown to bluish-black in color. The lesions are usually solitary and found on the head and the neck, or even the sacral region, and you can see it on the dorsal aspect of the hands and feet. Bathing trunk nevi, as you can see, it's all over the child's back. Erythema toxicum. This is a benign idiopathic, very common generalized transient eruption. It occurs in infants during the first week of life, and it consists of small papules or pustules, and they are sterile. So you'll see a red area with small yellow-white pustules like whiteheads. And it's important to know that it's non-infective. On gram stain, you'll see multiple eosinophils, and the rash often disappears within a few weeks, and they say within a fortnight. So this won't be treated. Here's a picture of erythema toxicum. As you can see, a red area with the white to yellow pustules, and this is how it appears on the trunk. Milia. Milia are small, benign, superficial, pearly white to yellow dome-shaped keratin-filled cysts that occur as multiple papules observed on the child's face, particularly in the area of the nose, forehead, or the forehead of infants. They represent simply blocked sebaceous glands. The superficial cysts rupture and empty their keratinous content onto the epithelial surface. It occurs in about 40% of term infants. This condition isn't treated because it will disappear after the first few weeks of life. Here's a picture of Milia. As you can see, there are white papules around the child's nose, and here is at the back of the child's head. Neonatal acne. This is only seen in 20% of newborns. It's characterized by the presence of predominant follicular comedones, blocked hair follicles. The whiteheads are about 1 to 3 millimeter skin-colored whitish papules found on the face and in the distribution similar to teenage acne. The erythematous papules and pustules can be found on the trunk as well as the proximal extremities, so on the child's chest or their shoulder. And this usually happens because of the progesterone levels from the mother being in the child's circulation, so it will resolve on its own. Here's a picture of neonatal acne. As you can see, it's on the child's cheek. You can see it here on the child's forehead. It will stay there for about the first 6 months of life. Jaundice. Jaundice is a skin manifestation of a disorder because it's not only yellowing of the eyes, it also happens in the mucous membranes and the skin. It happens in a cephalocaudal direction, meaning from the head down to the rest of the body. And you can check for jaundice in a child who is said to be more yellow than normal by putting them in a well-lit room and pressing down on their skin to blanch the yellowing of the skin to see the child's natural skin color. You have physiologic and pathological jaundice. The physiological jaundice usually happens because of immature liver cells, so it doesn't there is immature hepatic uptake and the conjugation process or increased enterohepatic circulation. Pathological jaundice happens when you have sepsis, rubella, or toxoplasmosis infection. And this is maternal infection, so the mother would have given the child the infection. Or it can happen because of occult hemorrhage or erythroblastoma fetalis. The reason why jaundice is so important in neonates and children overall is because of the risk of getting kernicterus. This is a neurological syndrome in which the unconjugated bilirubin deposits on the child's brain cells, and this can cause many problems in the development of the child. It's usually treated with phototherapy, and in severe cases or progressive cases, you will need the child to get an exchange transfusion. The causes of neonatal jaundice can be investigated based on what day it begins. So on day 1, it can be caused by rhesus isoimmunization, ABO incompatibility, and or torch infections or sepsis. Torch infections usually got this intrauterine. On day 2 can be day 1 or G6PD deficiency or pyruvate kinase deficiency, PKD, not polycystic kidney disease. Pyruvate kinase deficiency is an inherited disorder that affects the red blood cells leading to hemolysis. It can be life-threatening, and in infancy, Such individuals may require regular blood transfusions to survive. Okay, beyond 2 weeks, if you see jaundice in a child, this can be caused by hemolysis, hereditary glucuronidyltransferase deficiency, breast milk jaundice, or hypothyroidism, which is common in children with Down syndrome, or intestinal obstruction. Hereditary glucuronidyltransferase deficiency is an autosomal dominant disorder with variable penetrance. This disorder is also known as Crigler-Najjar syndrome, and it's basically impaired bilirubin conjugation. It causes impaired bilirubin conjugation. Okay, here's an asterisk disease. This is transient neonatal pustular melanosis. Look at this picture. This picture is gold. This picture is a picture you should know. This is a picture of transient neonatal pustular melanosis. This is a benign idiopathic disease which presents at birth. It's not commonly seen in the white population, and I'll leave you to guess why. We will see vesicles, superficial pustules which rupture easily, and this will result in pigmented macules which will stay there for about 1 to several months. This disorder is not treated because it will resolve on its own within several months. If you're lucky, it resolves within a month. Well, we've reached the end of this presentation. I hope you have learned a lot. If you've watched this presentation because you have a child with a rash and you're trying to figure out what to do, please see the nearest primary healthcare facility or your pediatrician. Let the professionals make the accurate diagnosis and treat your child with the best possible treatment. Thank you for watching.